I would now like to introduce Dr. Ayodeji Adegunsoye, Assistant Professor of Medicine at the University of Chicago.
Hi, everyone. Thank you for the invitation to speak on this important topic today. I'll cut right to the chase. I am Ayodeji Adegunsoye, an Assistant Professor at the University of Chicago. And over the last several years, a key focus of mine has been to identify predictive biomarkers or just general clinical markers at baseline ILD evaluation that help us guide therapy and management of this difficult disease. So today I'll be speaking on the topic predicting disease progression and outcomes in ILD for optimized patient care. As this is a prediction-focused talk, I'd like to let you know in advance that I'll be speaking a lot about our experience with diverse prognostic and theragnostic biomarkers on outcomes, and that means that I'll be showing you quite a few survival curves as well. For my disclosures, I've received grants from the Pulmonary Fibrosis Foundation, CHESS, the NIH, National Institute of Health, all for conducting studies in pulmonary fibrosis. I also serve on an IPF Educational Speaking Forum for Beringer Ingelheim. I'd like to begin by posing a rhetorical question. Why do we care about outcomes in interstitial lung disease and ILD? One of the most frequently cited issues in pulmonary fibrosis is the high mortality that we experience from having this disease. Now, a few years ago, a group from Seattle in Washington in the US published population data that really showed and depicted in a very nice way county-level mortality rates during the period 1980 to 2014 for chronic respiratory diseases here in the US. They showed us that deaths in patients with ILD had essentially doubled nationally, and in some cases actually tripled over the last 3 decades. So in clinical practice, it becomes really important for us to predict patients at the highest risk of death or of clinical decline so as to help guide therapy or targeted high-level interventions like pharmacotherapy or lung transplantation for this specific subset of patients. So when we think about clinical phenotypes that inform prognosis in ILD, perhaps the most validated prognostic scoring tool in pulmonary fibrosis still remains the GAP score. That's a score that's based on gender, age, and lung function physiologic metrics or indices like forced vital capacity and the DLCO. So due to its relative ease of use and prognostic value that we find from this metric, it's been widely adopted by researchers and clinicians alike. And there's actually an online calculator on the American College of Physicians website that helps practically implement its use in routine clinical encounters. However, increasingly we are finding that there are several other almost equally important physiologic indices and clinical phenotypes that can help us inform prognosis in ILD. And we will touch briefly on a few of these today, the ones you see on the right-hand side of your screen. So a few years ago, as we studied lung tissue from patients who had pulmonary fibrosis here at the University of Chicago, we noticed that patients with idiopathic pulmonary fibrosis, that's IPF, often had large lymph nodes, some of them as large as my thumb, right? And this was the case on chest CT scans, on explanted lungs from those who had lung transplantation, but the clinical significance of this was unknown. So thinking outside of the box, so in this case, the box of the lungs, we naturally asked ourselves, do these lymph nodes impact outcomes? So to answer this question, we here at Chicago undertook a retrospective multi-center study of over 1,000 patients who had a multidisciplinary diagnosis of ILD. Now, our institution is located on the south side of Chicago. So to replicate our findings, we selected a disparate group of patients from 4 tertiary facilities located primarily on the north side of the city. And we also selected a national randomized clinical trial cohort in patients who had IPF, and a geographically disparate center in California, literally on the west coast of the United States. So what did we find? Our findings actually, as you can see on the screen, were pretty striking. These are a couple of the survival curves or Kaplan-Meier curves that I talked about earlier. Now, they depict survival on the y-axis and time on the x-axis. Patients who had large lymph nodes, as you can see in the thick green lines, and are those with lymph node enlargement, and those without lymph node enlargement are those in the same green lines above. The separation of these survival curves was actually quite dramatic and consistent across all the centers. As you can see, the mortality pattern was greater amongst those who had large lymph nodes compared to those without. These findings, importantly, have also been replicated in other groups across the world, so in Japan and across the European continent, essentially. We also found that beyond the observation I just told you about, meaning large lymph nodes predict mortality, lymph node size, location, and counts actually also predicted hospitalization risk in patients who had ILD. We found that those who had these radiologic indices typically had a 50 to 70% increase in the incidence rate ratios for ILD exacerbations and subsequent hospitalization in their disease course. So, moving on, we talk about CT scans a lot, and when we obtain these HRCT scans of the chest and ILD, we often do not get these primarily to assess lymph nodes. We get them because we are often looking for features of fibrosis, and oftentimes we're searching for the most severe form of fibrosis, the honeycombing that we talk about often in ILD. Now, honeycombing is, as it's classically described, is defined as a diagnostic hallmark in IPF in a pattern known as the usual interstitial pneumonia pattern, the UIP pattern. But we are increasingly recognizing that beyond radiologic honeycombing, which is quite prevalent in IPF, it goes beyond just IPF alone. It's beginning to be more prevalent and recognized in other diverse forms of ILD. And when present, it does carry a worse prognosis, often conferring similar mortality to that seen in IPF. And so it's been used now to identify those who have a progressive fibrotic phenotype in diverse ILD subtypes. As you can see on the screen here, patients who have radiologic honeycombing outside of IPF in disease entities like chronic hypersensitivity pneumonitis, what we call fibrotic HP, and those with connective tissue disease-related ILD, the autoimmune disease-related forms of ILD, have a worse phenotype or worse clinical course when they have radiologic honeycombing as well. And so it can help to facilitate targeted intervention in these patients, irrespective of the ILD subtype. Once again, while we do know that IPF has the highest mortality rate when compared with other ILDs, the presence of radiologic honeycombing is common across the different subtypes, and there is substantial variability in its prevalence across these different forms of ILD. But we know that this common CT feature could be used to identify patients who have a progressive fatal form of lung disease, because the fraction of those who have this honeycombing who rapidly decline to death is unacceptably high. And so we often identify this as a practical way for defining clinical deterioration risk in patients who have ILD. Now, while patients with ILD may lack findings that are diagnostic of a specific connective tissue disease phenotype, they often will have features that suggest they have autoimmunity. And there was a recent ERS-ATS joint research statement that proposed research criteria to classify these patients as having what we call interstitial pneumonia with autoimmune features, IPAF. So in 2016, we retrospectively applied this new classification criteria system to data in the University of Chicago registry to help identify patients with ILD who met these IPAF criteria. We then characterized the clinical features, radiologic findings, the histopathologic features of this cohort, and compared them to those who had IPF or connective tissue disease. As you can see on your screen here, after stratifying by the presence of the usual interstitial pneumonia pattern I talked about earlier, typically which has honeycombing, the IPAF patients without the usual interstitial pneumonia pattern demonstrated a similar survival pattern to those who had connective tissue disease-related ILD, while those with the usual interstitial pneumonia pattern had survival that was pretty analogous to that seen in IPF. So how about other disease entities? So how about sleep apnea, for example? It's kind of a tale of two breathing disorders, and many of us have often wondered about this. So sleep apnea and IPF, how are they interrelated, and what impact may they have on clinical outcomes? Sleep disordered breathing is very common, particularly in IPF, and we know it's often a driver of disease, or at least a comorbid disorder in these individuals. They both cause hypoxia, they both impair quality of life, and they both affect millions of individuals worldwide. So when categorizing all-cause mortality by the requirement for oxygen supplementation amongst patients with ILD who performed polysomnography, those who required oxygen supplementation had worse mortality when compared to those who did not. Now, again, that may not really be surprising because obviously oxygen requirements often implies more severe disease. However, I will tell you that in a subset of patients, so secondary analysis, in a subset of patients with oxygen requirements, we found that CPAP therapy was associated with improved progression-free survival and with preservation of the forced vital capacity, that very important index that really helps determine the exercise capacity and ability to perform routine daily activities amongst individuals with ILD. Now, obviously, these findings were in a retrospective cohort and would need to be prospectively validated. So we'll switch gears for a minute here to talk about race and its impacts on outcomes in pulmonary fibrosis. We know that Blacks have high rates of respiratory impairment, and so thinking of race as a social determinant of disease, we hypothesize that African American race negatively impacts survival in ILD. So we performed a propensity matched analysis of ILD patients here at Chicago, and we found that self-identified Black patients had a slightly increased survival time of about 1.5 years, even after adjusting for metrics of disease severity, like the honeycomb I talked about earlier, like the GAP score I mentioned as well. And we confirmed this in the sensitivity analysis. Obviously, this was surprising to us and directly refuted our hypothesis. But perhaps the most intriguing aspect of our results was that Blacks developed symptomatic disease, and thus they were diagnosed with pulmonary fibrosis almost a decade earlier than others. Now, this is somewhat reminiscent of colorectal cancer, where the current guidelines recommend earlier screening in Blacks, and now it's been brought into the entire population here in the U.S. This huge difference across the races at age of diagnosis was also replicated in the Pulmonary Fibrosis Foundation registry on the right-hand side of your screen. So now thinking about that, if the 1.5-year increase in survival time for Blacks is completely abrogated by the diagnosis of pulmonary fibrosis in them a decade earlier, it raises the question of whether there truly is a survival benefit found in Blacks. And finally, I'll touch briefly on pharmacotherapy and telomeres, so a genetic marker that we often use in clinical practice. As you may already know, telomere biology-related molecules are critical to maintaining the stability of the genome. We often think about telomeres as the caps at the end of our shoelaces because they tend to protect the integrity of the DNA. Now, there's increasing evidence that points to telomere shortening as playing a key role in pulmonary fibrosis pathobiology and also in survival across the different ILD subtypes. Now, the data I'm showing you on your screen here was just published earlier this year, actually about 2 months ago, and it's regarding therapeutic response based on genetics in patients who have fibrotic HP. That's a hypersensitivity pneumonitis or a subtype of interstitial lung disease that results from exposure to environmental antigens. What we found was that amongst patients who had fibrotic hypersensitivity pneumonitis from Chicago, from Texas, from California, those with telomere lengths above the first quartile may actually have improved survival when compared with those without. So with the use of mycophenolate therapy, those with telomere lengths above the first quartile may have improved survival compared to those with telomere lengths in the second, third, and fourth quartiles. Now, obviously, this impacts how we think about the use of immunosuppressive therapy choices in this population, and also consideration for lung transplantation as well. So I know that was a brief whirlwind through, but in conclusion, I'd like to just state that the gender, the age, and the lung physiologic metrics that we think about often predict outcomes in ILD. And there are more novel predictors of survival outcomes in ILD, which now we begin to think about as including mediastinal lymphadenopathy, CT honeycombing, adherence to CPAP in those who have, requirements for supplemental oxygen in ILD, and also the autoimmune biomarkers as well. And then race, as we currently identify, may predict earlier onset of pulmonary fibrosis, as well as genetic heterogeneity in telomere length, as being a useful predictor of outcomes in patients with ILD. So I'll pass the torch on here to my other co-presenters, and I'll say thank you for listening.